All right, we're running late, so we're going to go ahead and get started. Ooh, we just got started. We only have 89 minutes and 55 seconds left. All right, so I've already taken roll, and y'all will all be glad to know that you are here. So, review the mission and vision statements for GTAC that is on here. I'm not going to read it to everyone, although we go through it every time, every quarter. Our mission is to improve care. Give some feedback on the last GTAC meeting of the actions that were taken. The policy that we sent forward on EMS transport to non-traditional facilities, so that was to extend it beyond just freestanding ERs, was passed. Additionally, y'all may be aware, we've talked for quite a while about changing the meetings from 3 days to 2 days, and after further discussion, GTAC voted on it and turned down that proposal. So the meetings will stay as is for the foreseeable future. Next item, number 3, which again is on here all the time just to make sure that we stay aware of it and see if there are any recommendations. Are there recommendations for new things or things that have come to mind that we should have on our medical director webpage? Mostly links. Putting documents is problematic, but links on our webpage that would be helpful to others. And Dr. Phillips actually brought up something, and I don't know where it's going to be at this meeting.
I think that would probably be in public comment time since it's not on the agenda.
Okay.
Officially.
All right. So
Dr. Greenberg,
everybody can wait on that. Yes, sir.
there is one, I'm assuming you can get it as a link. There is an Attorney General opinion about that deals with the mental health position statement that may be useful to link.
Okay.
And we can talk more about that in a bit.
So you want to talk about that with your mental health?
Yeah, but just as a link to add to the GTAC page.
Okay. I tell you what, why don't we jump down then, let Dr. Beeson give his report on the work group, and then we'll go into the mental health stuff.
Well, committee, we met, we discussed things, and then we adjourned.
Thank you for that report.
So we've had multiple phone conferences. I've I've missed a couple of them. They're just finishing up a meeting next door here. The registry is, I guess, what you call in beta testing, whatever beta is, with RACD. They are the state folks have gone out and did some training, and I think they're getting some preliminary data on that. The interesting thing is, in the last meeting here, the stakeholders meetings, representatives from all the committees brought up the concern is that although we have developed and built this great database, really didn't help anybody. Because I put my data in and I can get my data out, which is really good because I had it to begin with. And trauma hospitals can put their data in and they can get their data out, which really doesn't help them. And so they're over there now finally realizing that this really has to be a patient-centric process. The software company has relayed some capabilities they have built in already where I can share data with you and then open up certain fields. And so I think finally now, after years that, or actually months of this go-around, is that we may actually be on the verge of something that's helpful. So, more when it comes.
Any action we need to take? Or?
Negative, Ghost Rider.
Okay.
Thank you.
All right. Again, I'm going to jump around a little bit just because I think the mental health discussion will take some of our time. Is EMS for Children here?
Yes.
Can you? I won't make you sit through the rest of the stuff if you want to give your report now.
So our report is going to be brief. We just wanted to provide an update. In the past, we'd spoken about the Pediatric Protocol Resource Tool. As a follow-up to that, I just wanted to inform the committee that we received funding to build upon that, and so we're going to be embarking on a project to develop 4 more guidelines related to shock, spinal immobilization, allergic reactions, and airway management for pediatrics, pilot tested through Houston Fire Department, and then it's actually going to be implemented in all 6 New England states. And so once those are created, which will be sometime next year, those will be posted on our protocol resource tool site. In addition, I'm the American Academy of Pediatrics representative for the National Association of State EMS Officials Model EMS Clinical Guidelines Work Group. And so that project is well underway. The purpose of that project is to develop model EMS guidelines as a resource tool for voluntary use by EMS agencies as they choose, and they can be modified to the needs of the local area, the scope of practice, et cetera. We're in the process of developing drafts, and so I just want to inform the committee about this in terms of the timeline, because drafts will be available for public comment beginning in probably the late winter, early spring is our timeline. And so there are a lot of bright folks here in the room on the committee and elsewhere at GTAC. And so when it is available for public comment, we do encourage your commentary on that because the work group is very intent on trying to create a resource that is going to be useful for many EMS agencies across the country. And so when that comes, I'll provide further updates for you, but I just want to let you know about that. And from a pediatric perspective, each of those guidelines is going to be reviewed from a pediatric perspective, but they're being created with both adults and children in mind. Any questions?
I do. Can I ask? Got a question for you. With
Sure.
the NAMSP, the EMS physicians, and the American College of Surgeons statement come out on spinal mobilizations or spinal percussions recently, is the AAP or MSC thinking of a position in support of also of reduced use of spinal percussions, or are you aware of that?
I know that statement's come out. We haven't talked about coming up with a policy statement regarding that issue. I know that when our own project embarks upon creating an evidence-based guideline for spinal mobilization, any available resources, any literature or clinical practice guidelines that are already in existence will be reviewed and evaluated for incorporation. Your point about AAP endorsing something like that, that's something I can bring up since I'm also the chair of the EMS subcommittee for the AAP.
Well, it's just a hot topic in the state, and I think a lot of us are ready to make a big move, and the question is, we don't know where the pediatric world stands on it.
Sure. Yeah. So we can. I can bring this up with our EMS subcommittee. Usually, when the AAP issues a policy statement, it has to be vetted through the Committee on Pediatric Emergency Medicine. They meet twice a year. Their next meeting's in December, and so we can bring that up with them as well.
That evidence-based review did a few months ago on the C-spine, that was fantastic. Reviewed the literature and had all the salient features of what you need to go forward with that.
Oh, thank you.
And I just put the personal plea that I think all of us like to follow the guidelines with judgment, of course. The problem is when there's 4 guidelines on the same thing and they don't agree. So you get to follow one and not follow 3 others. So the closer they can come, the better for all of us.
Sure, and that's the intent with the NSEMSO project, is that it really incorporates stakeholder feedback. And so if there are things that are missing from those drafts when those are released, we welcome your feedback so that they can be a useful resource.
Any other questions?
Yeah, just one regarding the program you alluded to with piloted by Houston Fire Department in airway management. Can you tell us just a 30-second rundown on what that
Sure. So the project is starting. I had a prior grant, that's just ending now, where we created a evidence-based guideline for pediatric respiratory distress that focused on croup, bronchiolitis, and asthma management, and we implemented it in Dallas, Austin, and Houston. And so using a similar process modeled after the pre-hospital evidence-based guideline model process, we're going to develop evidence-based guidelines over the next year with a multidisciplinary group of EMS medical directors, pediatric emergency medicine physicians, pre-hospital providers, and parent representatives to come up with these 4 guidelines.
That's good. Anything else? All right.
Okay,
Sir.
thanks.
Appreciate it. Next, again, jumping around, since Joel, are you here to discuss some things for us?
Well, I thought I would talk to you.
I thought we'd just go ahead, I mean, rather than making you sit again through our discussion on mental health.
I'm going to be sitting here all day, so it's okay. Whatever you want to do.
I can probably manage you better than I can manage these guys.
Okay.
So number 7, recommendations to DSHS about Senate Bill 8, that short little bill that was passed. Can you give us some guidance on that?
Sure. So, we're required on January 1st to have recommendation to legislators on non-emergency transports, any changes to the laws, policy recommendations. I know the EMS group is going to be meeting 4 different stakeholder meetings around the state between now and November to receive input so they can give us a document. We're just looking for this committee to look at that, and if there's any recommendations that you have, to give it to us at the November meeting. And this is in direct response to the fraud and stuff that's been going on in the interfacility transport, the non-emergency interfacility transport within the state of Texas. So we had to do the report. We need it in November because we had to turn it in and get it through the approval process by about the middle of November, so we had it by January 1st as required. Does that help? Sure, you can.
I have a question for you, sir. So some of us recently have been working with Kathy and the medical board for requirements for EMS medical directors and part of CE ongoing initial training. I noticed in the thing you had up earlier, you have initial training and ongoing continuing education, but programs that are in existence past 8 years, I think is the time they're exempted. Can you explain?
So these are we're talking 2 different things.
Right.
One part of Senate Bill 8 was this requirement to do the non-emergency transport recommendation.
Right.
I'm assuming you're going to want me to go next into Senate Bill 8, like I did with the other 2 committees, and why don't we hold that over to that one if that's okay? 2 different parts of the law.
Sorry.
No, not a problem.
Premature.
What would be the best way for us to get information back to you? Because this is hard to get our hands around.
So I'm not 100% familiar with the system in Texas, being here just 2 months now, but I'm assuming that your recommendations go up through GTAC and then they send the recommendations over to us, but we're required to seek input from stakeholders on any recommendations that you may have on this issue. So that would be and Jane will be joining us eventually. She might say you can just give it to us directly, but you probably have to follow your normal process too.
But the problem is if we go by our normal process, we won't meet again until after the information will have needed to have been collected.
You'll be meeting in November.
Right.
And then we will be receiving that information like that day.
Okay.
And then we got to start writing right away to input we know that there will be a November meeting. And then we have to start right after that to write the report. So, and we'll have to confirm it with Jane. Maybe you can give it to us non-official at first, and then we get it officially through GTAC over. I don't know if that's legal or not, but
I guess my question is more, what parts are we actually reviewing? I mean, Senate Bill 8 is long.
Oh yeah,
And it's passed.
You are only reviewing. Your part is only 1 paragraph that says, give us recommendations on what we could do to prevent fraud and abuse and waste in the non-emergency transport system in Texas. That's the only thing that we're seeking input on.
Well, then that comes up under 15711, right?
Yes. Well,
It doesn't?
It doesn't. It's not. There's no law on that. It's just other than the law, Senate Bill 8. But there's nothing in the regs that would really address that, unless you know of some law in the rules that would address that we should change or something like that.
Yeah, here comes clarification.
So during the session, Representative Colcore, Senator Nelson, very concerned about fraud in the ambulance industry. And there was a lot of discussion about non-emergency transport issues. Should there be a different license type for them? Those kind of issues. And they've been discussed through GTAC in the past too. They decided not to go down that road during this session, although they did pass 8 and 3556, which have some significant pieces in there that they hope will reduce fraud. But what they have directed 3 agencies to do, HHSC has one piece, the Board of Medical Examiners has a piece, and DSHS has a piece. And we have met now with HHSC and the Board of Medical Examiners, and we're looking at trying to do one report out of the 3 agencies. We'll see what happens. We've already had to start working on the background information. We have deadlines that we have to meet for HHSC. But one piece of that is, as Joe said, we must get stakeholder input on any ideas they may have on how you can reduce fraud in the non-emergency transport piece of EMS in Texas, okay? When we were at that meeting with HHSC, they wanted our recommendations by October 1st, and we said we will only have one meeting of our stakeholders and it's not enough time. So we're going to get to turn around something within a couple of days. Actually, November 1st was when they wanted it, and we wanted that second meeting with you guys. So we have to turn around and have finished our piece of the report, including recommendations from stakeholders, by December 1st, which is going to be extremely challenging for us. So that's what we're talking about, is this report that is going to come from the 3 different agencies. It could still end up as 3 reports, but we think we're going to try to make it one, and that's what Joe is talking about. He's going to get to the other issues with 8 and 3, 5, 6 in a minute, but we have to report to the legislature by January 1st, and there may be an interim charge that comes out of this. And there was I know at least on the part of Representative Colkhorst, there was a desire to look further down the whole issue of non-emergency transports.
Okay.
Does that make sense?
So you really are looking for ideas from us, not a review from us?
No, we're looking for ideas, okay? So one idea that's been put on the table in the past is create a separate license. Have a license for non-emergency that is not an EMS license, okay? That's one idea. We look to you all experts for other potential ideas, okay?
One thing that came up in the EMS committee that I thought was a very interesting question was, what if somebody, under the new rule, got Brazoria County to say, okay, you can have an EMS service, and then they went into Harris County and worked all day and then went back home every night, Brazoria County.
Yeah.
How are we going to...
That's related to the rules that Joe's going to talk about in a few minutes, and the new law that talks about certificate of need. Okay, I'm putting that in quotes because that's not what it says. Okay, but everybody says it's certificate of need.
County approval.
County approval, and so that might be something. There are all kinds of things that you guys may come up with. You may say we actually need a little bit more formal process. I'm not putting words in your mouth, okay? For certificate of need related to non-emergency transports. Okay, so y'all may come up. We're looking to. They asked us to look to the stakeholders to provide input. We're going to give background on EMS in Texas and how long ago we started licensing and the explosion of providers in some parts of our states, and we're going to do all that background, and then there's going to be a section of our report that's going to say, here's the input we got from stakeholders and some of the ideas they came up with where there could be a reduction of fraud in the non-emergency transport business, because you all know it's happening, from taking people to kidney dialysis who don't really need to be in an ambulance, to the whole thing that happened in Houston with picking up people and taking them to community mental health centers, which nobody really defined, and having them sit around for an hour and then go back in their ambulance and go home, and then billing for that. Okay, so whatever ideas, we're looking for ideas from you guys. Does that help?
So with those ideas, does that includes compliance mechanisms as well?
Any ideas,
Okay.
everything. And we'll take the ideas. Y'all need to just decide how as a committee you want to put that together for us. Okay?
Kathy, one of the questions, do they have to come through GTAC or can they come right to us from the committee?
Generally, things come through GTAC. This is going to be a challenge for us to get this done by. So this, we had to quickly not only do the rules for 3556 and Senate Bill 8, as well as then get started on this report that's due January 1st. So we know we wanted to bring this to you today. I think we're going to take input, how we get input. Okay, I'm not going to commit. That's the preferred way to do it.
So if it's within the Open Meeting Act rules, can members of this committee email me ideas that I bring to the next committee for discussion?
Yeah. Just
And
don't
then-
have a discussion
Right.
on email.
Right, and
Okay?
then I will forward that to GTAC itself in November. So does that make, because I don't know that we can sit here and brainstorm in the amount of time we have. But we can do it in November if we have the ideas ahead of time, and I can put that on the agenda.
Do we have to have those ideas distributed among the members before the meeting? Can we
If you,
discuss that?
I think his idea is a great one, and we would be happy to help compile some of that for you, Dr. Greenberg, to then have it published on our website as a handout for the meeting so that all the stakeholders can have an opportunity to take a look at it.
That'd be great.
Mhm.
That'd be great.
Okay.
And we're going to get feedback in many different ways on this, so, like we always do in EMS. Okay?
Thank you.
All right, thanks.
So following up on that, if y'all, after this meeting or during this meeting, if you will email me some of your ideas, and they can be very vague, or they can be detailed, and then I imagine there'll be some duplication, so I'll summarize that. If you can get that to me by, when will we be putting the next agendas together? Nobody's in here that does the agendas.
30 days prior?
Well,
30 days prior?
you mean for the November meeting?
Mm-hmm.
About a month earlier or?
So by October 15th, how's that?
Yeah.
So if y'all can put that, send it to me by October 15th. And then I will compile that and submit that with my agenda so that it can be put out there. And again, it could just be little bullet points. We'll set aside agenda time for discussion. All right.
Can I add something? to
Of
what-
course you
what
can.
Kathy said?
We're only 23 minutes into the meeting. Go ahead. Yeah.
You're good.
How can you tell?
Subtraction.
So, the EMS committee, Chief Riley put out to all the committee chairs to look at this Senate Bill 8 and the stakeholder input. And the EMS committee looked at the Medical Transportation Task Force report that Chief Riley sent out from 2004 that Kathy referenced. And there's a lot of good, it's a good starting point. It is 10 years old. And so what our committee opted to do, we've been working on a number of these things and different ideas for months now. And a lot of it's already incorporated in 3556 and Senate Bill 8. But we've opted and we've already got meeting dates set. We'll be getting them to DSHS to publish these. But we're going to travel around the state on 4 different Fridays between now and November 1st and solicit stakeholder input. And if you guys could reach out to your peers, I think it would be fantastic if we had medical director presence at those meetings and not just EMS operators, because I think you guys offer a very good perspective from a different angle on things like compliance and on things like you guys are ED physicians. You know what you're responsible for when you send a patient out the door, whether they're being transferred to another facility or back home. And a lot of those things sometimes are beyond the purview of the folks who show up to some of these stakeholder meetings. So if we could have medical director input, those dates are, and these will go out formally through DSHS once the meetings get approved, but right now they're tentatively scheduled for September 27th in Houston at ESD number 1, October 11th in Harlingen. That's going to be at the, I don't know which hospital, I don't know if George is in here, I don't have that address written down. October 18th in Amarillo, and November 1st in Dallas. And we may, the week or two after November 1st, before conference, have another kind of wrap-up or Central Texas meeting in the Temple, Austin, San Antonio area, because we kind of circling the Central Texas area. So we may come back, depending upon the turnout and how people feel. If they think we need to have another meeting here, we may come back here. But I think direct medical director input would be huge on that, and we'd love to have you guys come participate, or your peers in those parts of the states come participate and let their and they're all going to be multi-hour meetings. They're all going to be slated, I think, from 10 to 3. So I don't know if we'll go 5 hours. But we'll go until nobody else has any other ideas or anything else to say. And so I think that'll be good. The other one, if you guys can go look at Senate Bill 8, I really do. I don't know. Kathy's talked about how the 3 agencies have met together. Each of the 3 agencies, HHSC, the Medical Board, and DSHS, have 3 different charges to get stakeholder input on. And from you guys' perspective as medical directors, it says the Texas Medical Board, let's see, I lost my place. There we go. The Texas Medical Board with stakeholder input and DSHS and HHSC needs to provide input regarding the laws and policies related to the delegation of healthcare services by physicians or medical directors to qualified emergency medical service personnel, and physician assessment of patients' needs for purposes of ambulatory transfer or transport or other purposes. When they start throwing words like delegated practice and that kind of thing in there, that makes me a little nervous, being a Texan and an EMS person in Texas. So I don't know if the Texas Medical Board's going to say, hey, we just did all this and we think that's good, or what they're going to do, but y'all may want to ask. They're kind of your agency. I ain't going there. I don't know how you let the attorneys get in charge of that, but anyway, I'm not going there. So anyway, I just wanted to bring those 2 things up, but we'd love to have physician participation in those stakeholder meetings we're going to have.
How about the county judges? Are they going to be involved or invited, since they're the ones that are going to be a key chokehold as to how many agencies are invited in their county?
I don't think
does it matter to, I mean, does this agency, I mean, at those 4 meetings, at least the judges in those areas, it wouldn't be a bad idea.
From my understanding, talking to their association people, I still think they're trying to figure out what that means and what their requirements are going to be. And I've encouraged them to reach out to DSHS to start having some meetings about what they're going to expect to see in those letters and what those letters mean, because the counties are really, and the cities too, are, wait a minute, what do you mean we have to, they're kind of lost on that, and they're not regulated by DSHS, but the product they're going to turn in could mean the future or not the future of an agency. So I think their issues are going to be wrapped up about what their requirements are. I think. I mean, that's where they are right now. They're very
Now the question came up
apoplectic
earlier: is do they need to be given the authority to inspect ambulances? Well, if they're given the authority to approve, do they not have the right to inspect what they're approving?
I don't know, sir.
Okay.
I thought it was a very interesting piece of legislation, sir.
Thank you, Doug.
Yeah, and why did you pass that? What were you thinking? Okay. So to add to the confusion, can we go forward and talk about section 157.11?
Sure.
Did you want to wait for Jane to show up?
Nope, I'm perfectly fine on this.
Okay. I got a text from her that she was coming. But.
So it might be helpful if Dudley, are you going to leave right this minute? No. So what we did with the AIR meeting is there's some recommendations made out from the EMS committee, and Dudley gave them out front, and it really helped a lot of questions later on. So if it's okay with you, sir, if he would just say, this is what he's going to push forward to GTAC tomorrow on additional questions and clarifications that he's looking for, then I'll go through the bill. Okay.
So we're going to take the GTAC recommendations for them to ask for clarification on these 5 areas. There's lines in the legislation that are now in the rule that says if you are directly operated by a governmental entity, you're exempt. And the EMS committee feels we need more clarification on directly operated by because of the relationship between 501c3s and ESDs. There's language in there about a surety bond that has to be payable to HHSC. The language that HHSC is currently promulgating that is going to be the language that's going to regulate that has different requirements and some different wording than what's in the DSHS language. And so we're going to ask for DSHS to seek clarification not only in that language but from HHSC as to what they're finally going to do so that they equal. because the way they're both written now, there's the chance that DSHS may require an EMS agency to produce a bond that payable to HHSC if they default, that HHSC is not yet requiring them to produce to them themselves. So it's to clear it up so that we're not pitting agencies in the middle between DSHS and HHSC. On the county city letter, there's a lot of interest on the air medical guys because new providers who come in and get a new provider license have to get that, and they can't operate outside of that city or county boundary for the first 2 years of their license unless it's for mutual aid or disaster or they get another contract. And the air medical providers are concerned because rarely do air medical providers operate in a single city or county. They usually traverse those bounds pretty easily. And so we're going to ask for clarification on does that apply to upstart air medical providers. Clarification on the county city letter that is required, and does that mean that they can only operate in that jurisdiction they have the letter from, or is that where their base is and they could go into the jurisdiction next door to pick patients up? So we're seeking clarification on that. And then clarification and or an example or both of the letter of credit language, what that document needs to look like so that agencies will have an example to take to their bank. Because when you say letter of credit, there's 2 or 3 different things people think that may be. And so we're asking for clarification and maybe even an example that agencies could take with them to the bank to make sure they're getting the right document and paying no more than what they have to pay to get those documents prepared by the bank.
Thank you, sir. So is there anything you need out of us on that? Because some of that I think is clearly so operator dependent that like the bonds and that kind of stuff. I'm not sure
we did this so that you'd understand what we're taking forward. He's going to run through the language they're recommending changing. There's probably going to be 2 or 3 things you guys are like, hey, what about this? So we were just briefing what we're going to take forward. Either you guys take something, that way we're not repeating. Okay. If you see something, hey, that seems odd, how's that surety bond going to work? We're already asking that question.
Okay.
Dudley, you asked or mentioned the clarification on air medical. What do we think that clarification should look like or will look like?
I have no idea.
So we'll see what the response is first before we do.
I was talking to some air medical folks. 157 is an unusual animal because it has a lot of things that apply to everybody, and it has some things that just apply to ground. And so the clarification, I think, is everything that's being added going to apply to air medical. Air medical was never discussed when that law was being passed. Like I told the air medical group, we were too busy fighting amongst ourselves on the ground. We couldn't swat at the air, so we didn't even have a chance to even talk about air. And so that was never really included in any of those discussions. But 157 has things in it. Helicopters don't have to carry road triangles on them, but ground ambulances do. So that kind of thing. So I'm not really sure. That was the reason we were seeking clarification. It's just too much really to answer here.
So we shouldn't get excited yet.
Not yet.
Well, and I'll just tell you my opinion on the aeromedical part. If they're flying to a scene, well, that's a mutual aid sort of a response, in my opinion. If they're flying to a hospital, that's a hospital's request. Once again, I think that's, somebody just puts a clarification that that's considered a mutual aid response.
And the law is very clear about what you're calling a mutual aid or a disaster response also. It says it's exempt from that. It doesn't say interfacility, and that's where the confusion comes.
And the law was, the people who promulgated that language forward and then it got melted into this, their original idea was that you would be in the area you got licensed to operate in at least for the first 2 years to prevent I'm going to get licensed in Fort Bend County so DSHS doesn't look at me, but I'm going to do all my work in Harris County.
Right.
Sean Salter, San Antonio Air Life and Air Methods. For the question regarding what impact it will likely have, we have a previous opinion from the state attorney for Texas that the Airline Deregulation Act would basically federally preempt the state from enacting any rules that interferes with rates, routes, or services for air ambulance. So it likely would have no impact.
What percentage of air, fixed wing or rotor wing is involved in what Senate Bill 8 is really talking about, non-emergency transport?
Agree, and I think to Mr. Schmitter's point, I think it's the fact that the way that the provider license is set up.
Who's paying for non-emergency helicopter use?
Right.
I would.
Lots of fixed wing.
Some by fixed wing.
There's a lot of fixed.
Yeah, but that's usually privately paid, right?
Yeah.
Yeah, it's pre-approved.
Pre-approved insurance, yeah.
So let me just run through this, and this worked really well, the other committee with Dudley saying, here's where we're all, here's the questions already, and I'll run through this, and it actually ends up saving us some time in the long run. So the yellow is actually the language right from the law, and the black bold is being deleted, so we're not calling them candidates anymore, they're applicants. You want to just drop one down? Keep on going. So the first big part of the new rules is the administrator of records, and there's some qualifications now for this person. And again, the yellow is right from the law. The white is what we've added in just to make it a little bit clearer. But the person, first of all, cannot work for more than one private for-profit emergency medical services provider. And when we say that, we mean as an administrator of record. So I could be an administrator of record at one service and be a volunteer or an employee at another service, but as administrator of records, it's only one person. And keeping in the back of your mind that this legislation was written due to the fraud and waste and abuse of the system. And it would be very, and I'm sure there's documented cases where as administrator of record, I work for two different companies and I like your company better than this company, so I put me out of business and push all my work toward the other person. So it's to clean that up a little bit. The person has to be qualified as at least an EMT or certified in a related field in the state of Texas. So we just want to make sure they have some background understanding of EMS when they go into this role as administrative record. They must submit to the same criminal background check that an EMS provider must. They have to do continuing education as well as initial education on the rules and regulations, rules and statute on the EMS law in Texas as well as the federal laws. And we added in the federal, the bill itself just said state laws, but it just seemed to make sense that they should know the federal requirements also. And they have not been excluded from the Medicare or Medicaid program. And if the person has been in this role at least 8 years already, they're exempt from having to meet this requirement. So that's the requirements for the AOR, the Administrator of Records. Let me stop there, see if any questions, because it seems to work better when we break it up into some different sections.
I've got one question.
Sure, sir.
The 8-year exemption, so in other words, I've been the Administrator of Record for 8 years. I'm assuming that's only for the initial education. Do they still have to comply with the 8 hours of continuing annual
Yes, sir.
CE? Okay.
Yes, sir. Any other questions?
Any other questions?
Any discussion about where that training is going to come from?
We had to develop it or at least approve it. So I'll be honest with you, I know there's some national programs out there for administrators. We may approve some of them, but literally we've just been writing this, and thank God we have a year to fill in the details.
Fair enough.
All right. Anything else? All right, let's move forward.
And a government entity is exempt from that requirement.
From all requirements?
From that requirement. And there's some other stuff where they're not.
But I mean, as far as the ongoing
Yes.
CE, they're exempt.
How about private, not-for-profit?
They are not exempt. It says very clearly just operated by government entities. You can stop there. Number K is the employment of the medical director, and that doesn't mean they have to be paid, but they have to have an agreement, contract, some kind of relationship with the medical director to oversee their organization, to be a part of the organization. That's a requirement.
Yeah, and the word employed came from the law, correct?
It did, sir.
Right, so we had a call about this recently. I think it's just interpretation of employed, and contracted with is probably something we would prefer, but like you said, it doesn't mean that they're an employee of the ambulance service. It just means that they're the medical director. That was the intent.
Yep. And we've checked, and we looked at a couple different dictionaries, and definitions of employed, and none of the requirements means payment. This says you have an association, an agreement, a contract, an MOU, something, but it doesn't. It can be, but it doesn't have to be. So the next section we get into is the applicant, which is the person or corporation that's opening up an EMS agency for the first time. So again, the yellow is the language from the statute. The white underline is what we're adding into this. So one of the requirements is that they have to have a professional experience and qualifications related to EMS and be licensed in tech. Or I'm sorry, let me back up. It has to be professionally experienced and qualifications related to EMS in their personal life here, in their education and training. So for that, we added in 6 other bullet points. One said that they're going to do a test to this. They're going to sign a document. It's going to be a check of a box. It could be a resume, a CV, something. It's going to be a low hurdle to get over, but I think it's a good hurdle to get over. They have some experience in running EMS. And the first one is that they have to have read and understand the laws and rules of the EMS system. They have to have a knowledge and experience in human resources, recruitment and retention. They have to understand EMS dispatch. They have to understand medical control. Thank you. Medical control, quality assurance, and there was one more, what did I miss? Medical control, quality assurance, budget and financing. So, and these I really truly just took from a book written by Jay Fitchson. These are like key foundations of any organization if you're going to run EMS. And again, this is really, and it was really interesting. About 2 or 3 weeks ago, I got a phone call from a gentleman trying to open up an EMS agency, an EMS organization in Texas. And he said, well, I was talking to him, and he was really concerned about the moratorium, as you know, starts on September 1st, goes to August 31st, 2014. So we can't issue any new licenses during that period unless it's for a contract or for emergency services. And when I say contract, a contract to government to provide emergency services. His question to me was, sir, can you just answer this question, what does BLS stand for? And I was kind of like taken back, and I'm thinking, here's a gentleman wants to get into the EMS business and doesn't know what BLS stands for. So I think this is going to at least address that issue, that it's going to require some understanding of EMS if you're going to get into that business. And we set it up in such a way that if it's a corporation, that we're not expecting the CEO to have all this, but that the corporation has a human resources department, that they have a budgeting department, those kind of key components that you need to run an organization.
Could I ask a quick question about
Sure you
the
can.
very first point I up there, UI, go up a little bit. It says that the EMS staff has read and understand, so that means the line EMTs and paramedics, they're certifying that all of them have read and understand all the rules.
And we're not referring to the staff as being the providers. This is more in the management staff.
Well, it says management staff and EMS staff.
Yeah, it still is designed for the management staff. So we'll take that question back and clarify that.
Okay.
But
Can I ask a question kind of off subject a little bit? Have you seen a big increase in applications trying to beat the September 1st deadline?
no,
Really? Okay. It's interesting.
we have some, but there was no big rush.
So as a thought, if one of the main intents behind the new rule is to decrease Medicaid fraud, would it be appropriate to say that they've attested that they understand what those rules are, that they're not violating?
And that's why, you mean to say Medicaid directly, and that's why we said federal laws. We didn't really say Medicaid, or we just said federal laws, to make it more general.
Now can I ask my question?
Sure you can.
So, the 8-year exemption, what's the purpose of exempting those who've been doing this for 8 years from continuing ongoing? We just went through with the medical board, and we now, who've been doing this for a while, still have to do continuing education on an annual basis to maintain a medical director. So we're not exempted, so why would we exempt people?
We're not exempting them from doing a continuing education. They're exempt from the initial training requirements if they've been doing this for at least 8 years.
That's what you asked earlier, right?
Yeah.
You clarified. So I just had a brain fart, forgive me.
Yeah, that's all right. That's all right.
Second of all, the governmental entity was brought up earlier. If you'll notice in the back of the magazine, there's a substantial number of governmental entities that are there for being not applying by the rules that are set forth.
Sure.
So what's the purpose of exempting anybody?
You know, I wish I could tell you that there was an excuse for how that happened. I don't know the answer to that. I wasn't here for that. But I can tell you that the law is the law, and they're exempt. And there's nothing we can do about that, and we can't change that in rule because the law is the law.
There was an effort
There was an effort
to
for...
make it apply to everybody.
Oh, okay.
So is the anticipated impact for volunteer agencies, because there are some who may be involved in non-emergent transport and things, that they would be essentially, any or all of those would be associated with governmental entities, so probably no impact on those? Is that
If they're associated with a government entity, they're exempt through the majority of this. Okay. Okay, so the next is the line of credit, and this is for new applicants or anybody who's not been in business for a for-profit or a company that's not been in business for at least 10 years. And what this means is that they have to produce a line of credit from a bank or a savings institute, federally insured, for the first 4 years of $100,000. For the next 2 years after that, the 5 and 6 for $75,000. 7 and 8 for $50,000, and 8 and 9 for $25,000. And this is not a bond. They give us a document or a letterhead from the bank saying that they can get this line of credit, and they produce that. And I think what they're trying to do there is to show that they have the financial capability to survive the initial startup of the company, and they're going to be here for a little bit. If a company has been in existence, let's say for 6 years, and make sure I'm doing this right, so they would still have to produce a bond for $75,000 or $50,000, and then they go down to 25. So that's in there, and again, government entity is excused from that, and it just talks about, you know, the language there just talks about that it has to be on a document from a bank. Any questions on that? Okay. So the next one is the $50,000. Now this is a bond, a security bond that would go to HHSC annually. Now the real question there is it a time of renewal, or if we check every 2 years and they check every 5 years? That was a question that was raised this morning. We have to go back to HHSC and try to get a clarification on that. But again, this is a $50,000 bond made to HHSC. So that I guess if you don't pay your bills or you take money fraudulently, they can go against your bond for that. But this is even more formal. And apparently that already exists if you're in the business of hospital equipment or home health care equipment. HHS requires that if you're delivering that to people now. And again, the only other part of that is for the $50,000 and for HHSC, if you've been excluded from Medicaid or Medicare, you're not eligible to participate in this program. And then the final part of the regulations is the government letter approval. And this is if you're going to open up a new service, that you have to go to your county and or local municipality, and they have to document and give a letter of approval which says they took into consideration that you're not oversaturating the area, that you're not going to have an adverse effect on somebody that already exists there, that you're not going to expand for the first 2 think that includes the majority of that.
So this is the non-certificate of need, certificate of need portion.
That's correct, Doctor.
Just the rose by any other name.
Yes. And, you know, the language that's in the rule itself is literally right from the Senate Bill 8, to put right in there. As you heard from Dudley and from other people, there's been a lot of questions about that. How does that affect air ambulances? I mean, that's a good question. And the municipalities are going to be looking for us for some guidance on maybe best practices or something like that on what does that letter look like. And we'll work with them on that. So that's really the changes that's coming in. That's the rule that we're pushing forward for approval, I guess, at the November meeting from GTAC. And with everything, if everything goes in line, this will go into place around June of next year. And that is all that's in this. I know there's a lot of other issues with 157, a whole bunch of different numbers that we want to get to, but you know, we started down that road looking at maybe adding some of those other things, but this is pretty black and white. It's better off to leave that for another fight, another day, because we would never get it through in time, for sure. So we'll go down that road, but it just won't be with this bill. And with that, I'll take any questions. Great.
We already asked them, we're sorry.
Can I make one little edit? This rule is going forward. It will go to not to the GTAC in November. It will go to HHSC Council in November. So it's going to go. It's going to be in the pipeline past GTAC. Okay.
So is it on the GTAC agenda for this meeting?
Yes, it is.
So if there's something that you want this time, so no discussion about the non-certificate of need, certificate of need?
The underlying part seems like discussion might be a little bit pointless.
Yes. Well, I think we have to have confidence in Sean's comment regarding aeromedical and the federal oversight and the Attorney General's opinion, because if that doesn't take place, I think that's a whole other ball of wax. Lots of discussion.
I am not an attorney.
All right. Thank you.
Thank you.
We'll jump down one more, number 9, about the review and input on the coordinating board for EMS. I have the document. It was in a packet that I have. I don't know if everyone else has it or not, or if it's the continuing education coordinating board for EMS revisions. Don't you sit on this? Anybody sit on this? Anybody seen this document?
No.
Does this need, when is action going to be taken on this? Blank book? Yep.
Soon.
You took a look at it.
So the question I have, it talks nothing in here, and this is one of the concerns that medical directors have had for programs applying for continuing education. There's no requirement for any medical director involvement, approval of the program or anything. I do notice in here it does require the medical director's name and or signature on the certificates. So in a sense, an organization that the medical director for could apply for a CE program unbeknownst to me. I'm their EMS medical director. They print my name on the certificate, and I have no knowledge of any of this.
Thank you very much.
That's somewhat concerning.
Jeff, I am a C-SPEEDS reviewer.
Okay.
Although I haven't been privy to this sort of stuff. But actually, the medical director's CV has to be included in that application, and they have to sign that application as well. So they can't really apply for you to become a CE entity without the medical director's knowledge.
What about, I understand you established, but when you get approval for a specific program, is it on that application?
Yes.
Okay, then I was misinformed. Sorry, thank you.
Want to be a C-SPEEDS reviewer?
No.
It's the next to last bullet that's being displayed right now that Dr. Beeson's asking about.
And I don't know the application that clearly, but I think you might have a valid question, Doctor. Is it just your signature, or is it your approval and signature? And I don't know if somebody else knows the answer to that. I think that's your question, because they could just put your name on there, type it in, saying. Not that anybody would do that.
That's what's done now.
During the review process, the question that the reviewer is asked is there evidence of medical director involvement and approval?
Okay.
I believe is the way that it's worded. I haven't done a review now in about a year, and I've actually got one on my desk that they're wanting me to do, but I believe that that's the way that that's actually worded.
Okay. Thanks, Tom.
So you have what that is? Okay. This document is on the webpage, is
Yes.
that correct?
Yes.
So I would ask everyone to take a look at it, see if you have any heartburn over it. All right. So let's now jump into agenda item number 4. This comes from the last meeting we had where we were discussing mental health issues in EMS and emergency care. Dr. Jarvis jumped on the hand grenade and volunteered to come up with a position statement, and you now have that draft before you. It is being displayed on the board. I think probably let's just go straight down to recommendations. Not that the first part is unimportant, but I think the recommendations are really what we should discuss, or the position. And I will turn it over to Dr. Jarvis.
So jumped on the grenade was a euphemism for I'm about to be pushed onto the grenade. Thank you, Dr. Greenberg. So what I tried to do with this is I was having a hard time really getting my hands around what the problem was. I recognize it when I see it, but it was hard to actually put it into words. So I tried to define what the problem was, and then tried to make some recommendations on what I think might be useful to solve the problem. And obviously, as I'm writing this, it's rather me-centric. So it's designed to address the issues that I'm seeing. And one of the nice things about the big draft word on there is if it is not addressing some of the issues that other folks are seeing, please let me know, because we want to make it a very inclusive document for it to be any good. One of the big issues that we seem to struggle with is getting mental health patients into an appropriate mental health facility. We run into a problem where they require a medical clearance exam. Well, a medical clearance exam isn't really defined. And from an ER doctor standpoint, medical clearance exam seems to me to be defined as whatever it's going to take to make sure the patient shows up after my shift is over. So it appears to me to be a stalling mechanism. Now, in defense of the folks in the mental health facilities, I understand their rationale for wanting to make sure that the patient doesn't have either an underlying or concomitant medical disorder that they're not equipped to treat. I understand that. So there is a decent reason for having it there. The problem is that frequently what they say they want is potassium or some lab test that to me is not in the least bit clear is going to actually help provide a medical clearance exam. So the definition seems to be very nebulous, and I think it would be very useful if we could actually come up with a standard definition and get people to agree that yes, that's the definition we're going to require. So I wanted us to work with the relevant people involved to create that standard definition. I also felt like if we have a definition, it would be nice to have everybody agree to stick with that definition, and I think the best way to do that is to work with the professional associations that are representing all of the stakeholders, if you will, EMS, law enforcement, as well as the inpatient psychiatric facilities. And that's where I'm thinking we need to ask for the endorsement of that definition of medical clearance exam. Finally, we want to look at seeing if there is some way that we can bypass emergency departments with taking patients who need mental health, defining who those patients are, and taking them directly to a mental health facility. This is clearly being done in some places and being done successfully. It's not being done universally. I know we run into roadblocks, and I suspect a lot of y'all run into the same roadblocks. What we'd like to do is see if we can define a segment of the population that we see that we can bypass the emergency department for. Can EMS provide that medical clearance exam? And then truly the last thing is one of the issues that's come up repeatedly is the power, the ability to do a ordered emergency detention. Essentially an involuntary hold on someone we have reason to believe is a danger to themselves or others. Obviously this draft legislation on this has come up repeatedly and so far hasn't been successful, but I think it's something that is very much needed. So I would like this committee to also include that in the recommendation.
Discussion? And any feedback from DSHS if you think this is outside the realm?
So, only real concern I have is it would be nice for the standardization, but I think other positions and other things this committee's done in the past has been very practice dependent. I would recommend some of the wording be more to your local practice or your local service area that you work with versus a larger standardization of things, because I think even within my service area, the psychiatric facilities I have can't agree on whatever numbers of ETOH or whatever they will or won't take. But it's definitely a local issue. The only other thing I would suggest, number 4, the law already has the ability for non-law enforcement people to do this. It's obviously not EMS personnel, but I think if you put that forth, the answer will be, well, you already, physicians have the ability to do that. So.
Yeah, I think there's some substantial disagreement about whether we have that.
No, I completely agree with you.
I don't think we have it. Certainly our attorney thinks we don't have it. So I think there's some substantial disagreement and yeah, we get that too. Well, you already have it. And I think you already have it seems to be a euphemism for we don't want to do it.
So my recommendation would be that we just word it more to your local practice service area, more integrating with your local healthcare communities and your local facilities than a more broad thing that we need standardization and national groups to agree. In the ideal world, I agree, but in the past, other things that this committee's put forth has been very, when we had the other chair, Steve.
I'm just going to back up and look at okay. I'm not sure if that was on you or on me.
Take it either way. So anyway, that's my only concern about this.
So which part are you? If we're going to wordsmith.
Well, I haven't read the entire thing. I'm just reading the problem. So that's
right.
the first part.
It's very juicy.
Position.
The
yeah.
position
It'll keep you up
really
at night.
the part that we.
So professional associations representing law enforcement and patients endorsement of a medical clearance examination. My recommendation would be that we put in somehow worded that it's in your area, your local area, that you're doing this in your practice area, not that we as a committee are saying that this should be a statewide mandated thing.
So
the problem with the local thing is that they may have unreasonable standards in the local psychiatric facility. That's the reason the Greg Abbott ruling was so important, I think, and that is that EMS shouldn't be involved at all, that the sheriff should be taking them directly to the psych facility. That's the state law. It has nothing to do with EMS.
Well, I agree with you completely.
So we're really kind of subverting the law in approving this. But if we're going to do anything that improves care in Texas, we ought to get the entire psychiatric community to have to agree on a standard. And the ones that are way out there, if it happens to be the one in your community that requires a blood alcohol less than, 60 or something, then that person will get voted down. If Carroll State Hospital requires 120 and Russ State Hospital requires 150, that's unreasonable. They ought to, at some point, as psychiatric facilities, since they're subverting the law anyhow, have to agree on something on a state level.
So if you're going to break the law, do it consistently?
Yeah, at least on our state basis.
Well, if you open that door, they're going to want to set the level so high, they're going to require a CT scan on everybody.
Exactly.
CYA.
Yeah, and that's what I'm reading.
They're seeing things that could be a lesion, so you better want to CT their foot.
Well, if they get to the state facility or to any psychiatric facility and the psychiatrist is worried, they're going to send them right back to your emergency room. So they're going to get their CT if they want it.
So our goal is really to get a subset of patients that we think is safe directly to a mental health facility with not having to undergo emergency department evaluation. I think we probably all feel that that's a admirable goal, trying to find the dynamics to make that happen, especially when we can't even in the emergency department come up with what a medical clearance examination is. And so that terminology, I know you have it in quotes, Jeff, and I don't know what the answer is, but is there some other terminology that we can come up with that implies an EMS evaluation and we feel that they are at somewhat low risk and that they could be taken to one of these mental health facilities directly? And I don't know if that, just because we associate medical clearance examination with all those things, an alcohol level, CT scan if there's any bruising or trauma, all those, sodium level if they're on some kind of medication. Is there some other words, and I don't know off the top of my head, but is there something else that maybe has been batted around or thought about that we could?
So that's the reason I put it in there is because that's what we're always presented with is, hey, you need to go, well, what is a medical clearance exam? Well, it's labs. Which labs? Oh, I don't care, just, labs. Okay. So what my intent was is there were several things. One is to, yes, bypass the emergency departments and get the patients to where they can actually get some help. But two, if they are going to end up in emergency departments, let's try to actually standardize what they're there for as best we can. And then third is help with the involuntary detention. Going back to the whether this is a local issue or a state issue, the reason what I would like, we can't, and I think it's unreasonable for DSHS to mandate this. I don't think that's not really what I'm asking for. What I'm asking for is to get a voluntary consensus among the different professional organizations to say this is what we're looking for. Now each local place can still go against that and say no, we need an alcohol of 2. But then we have an additional tool to say, look, I think that's unreasonable, and so does your professional organization. So it's essentially additional support for us when we're making our arguments. And that was my intent to make it a statewide issue.
So around the state, there are a number of programs that are doing this and have probably relatively close requirements. They're maybe not exact, but maybe worthwhile to try and review those, or perhaps you already have. And then I think on the national level, isn't Ray coordinating a meeting at the American College of Emergency Physicians to try and bring people from around the country and to address similar type of issue, finding out what best practices are with alternate destinations from EMS for mental health patients and things. So.
Yeah, the task force from ACEP was primarily focused on sobering centers, but it's, in a word, trying to identify a subset of population that can safely be transported to alternative destinations. So instead of wording, just simply, in a sense, trying to identify a subset of population, mental health patients, chemical dependents that can safely be transported to alternative destinations, not an acute healthcare facility.
Yeah, I think it's a great idea. It's just trying to come through some of the mechanics of doing this, and this is certainly a great initial work to make that happen.
So, is number 3, just number 3 on this? How does that look for that issue of taking patients directly to non-emergency departments?
I would just recommend that instead of being a situation that we somehow identify a subset of the patient population that can be transported to alternative destinations.
Is that something we should wait on the national ACEP meeting to see if?
Well, this is just a committee that's getting together.
Yeah, they're just getting started, so I don't know that they can't be
There won't be
working
anything
parallel because we don't have anything done anytime soon.
Okay, so seems like number 3 is the least controversial of this. I heard Dr. Beeson basically say change it from situations to patients. In other words,
Subset of patients.
Yeah, determine if there are patients whom EMS would be able to perform.
and then leave that vague, and then it always comes down to the medic discretion, that there are those cases it's safe to go to non-traditional facilities. I think it's always going to be their onus to put it together and say, okay, this patient, in my opinion, is safe to go without going to the ER.
So anything else on number 3?
I think the medical clearance piece still has connotations that go with that. And so, if there's the potential to make it even more generic, and then something along, in which EMS personnel would be able to perform evaluations and transport directly to an inpatient, it leaves it open, but I think the connotation of a medical clearance examination just will throw up a lot of red flags.
How about
personally.
medical stability or medical stable?
Does that
Or
have
just
any impact on our
appropriateness?
EMS providers, that it could come back on them if we say performed a MABEL or a medical stability exam? I don't know.
So perhaps this is what Dr. Beeson was saying, determine if there's a subset of patients that EMS personnel could safely transport directly to inpatient.
Right, just take the medical clearance exam out and just identify a subset of population that can safely be transported to, directly to psychiatric facilities.
It would be interesting to know across the state what percentage of our medical screening exams in the emergency departments throughout result in any medical findings.
Yeah, I agree.
Everybody found that TSH
was being the problem.
Yeah. So I would suggest, Jeff, that really number 3 is what we're talking about. So 1 and 2 would be done by determining a subset of population that could be safely. So number 3 is your statement. In addition, collaborative, then number 4 is something in addition that should be done. But really the position of us is in a sense that number 3. Number 3 will be achieved by doing 1s and 2s, working and identifying that subset of population, but I don't think you have to say all that.
Yeah, I guess from my perspective, I think we may be able to combine 1 and 2, but I think trying to define what they're looking for, whether we call it a medical clearance exam or whether we call it something else, but trying to get their professional associations to help us define what they're looking for, I think would be very useful.
Would there be any way we could meet with them?
Well,
or send a representative to one of their meetings, or have one of their representatives come to this meeting, or 2 or 3 of their representatives?
Well, that's really what I was asking for in the position description, is that we work with them to try to determine that, and I think that would be the best way to do it.
To have a joint task force meeting.
Jane, is there another group within DSHS that represents mental health, psychiatric?
There's actually a division. It's a division of substance abuse and mental health. Mike Maples is the, would he be section or assistant commissioner? So it's a totally different division. But yes, we can have those conversations.
Do they have an advisory committee or a?
You know, I don't know. I'm going to have to really ask some questions to find out. We've worked with them on some of the requirements for was it the substance abuse rules for psych hospitals. We've worked with that, and that was out of our health facility sections, mostly the folks out of that and hospital licensing. But I'll need to make some inquiries and let you know.
I believe this is a big enough issue. We would be willing to meet with them on their terms or have them come in.
And
everybody agree with that?
Yeah, I think Jeff Jarvis would be a wonderful representative for us.
Yes, the remnants of the initial grenade are still there, certainly. I just think when we go to them, it would be more helpful to say, look, this is the reason we're here. The Medical Directors Committee has found that this is an issue. and we're reaching out to y'all to help solve it. It's not just me being here, it's me being here as a representative of the committee.
And it's really bigger than just a medical screening exam. I can complete a medical screening exam in about 30 minutes. And yet their time in my emergency room goes from an average of 4 hours to nearly 8 hours if it's a psych patient. The comparison is almost double in terms of the time, and that's on an average. So we have some that are with us for 24 hours. So the issue is not just the medical screening exam. That's not a big problem. It's the placement issues and the waiting on a social worker or somebody to come and interview the patient. It's the delays and repeated delays that in any other health setting would be unacceptable, but in the psych community it seems to be the standard, and we're allowing it, and it's just not good patient care, because if those patients need true psychiatric treatment after the medical screening exam, we're delaying to the point of being a little ridiculous at times.
I just wanted, I just wanted to address that comment. We're very well aware. We've had complaints from hospitals actually coming into the department about psychiatric patients being inappropriately held and kept for days on end, and them not being able to find a private psych facility to send them to. So about a year ago, me and my staff worked with THA to have a stakeholder meeting statewide to bring in people to discuss this issue. The bottom line is that there is not sufficient capacity in the state, either through our state hospital or psychiatric beds. And the way that the judges in Texas view it, patients who are held with for what is that, Jane, called a warrantless emergency? Yeah, whatever I'm talking, you know what I'm talking about. When they're held, they feel that a hospital is an appropriate place for these people to be treated, and as such, we put out the word through our communication with THA that they should give proper training and intervention training, etc., to hospital staff, because this problem is not going away.
Yeah, the problem we have is that this is an enormous expense on our hospitals. They're not just bed down in our emergency room. They have to have a sitter 24/7, and that sitter cannot physically take their eyes off of them. They can't go down the hall and kind of cover 2 or 3 rooms. They have to be individual to that patient, and we've had inspections in our hospital where inspectors dinged us for not having immediate presence of that sitter in front of every patient that's being held.
Yeah, the bigger
that's the bigger issue.
The bigger issue is when they get stuck in our emergency departments, all the other regulatory agencies come after us. CMS, one of them. What Dr. Morris is talking about, we have to watch them completely, 100% can't take your eyes off of them. We actually got in trouble because we were watching them too close, because that was infringing on their rights. So it kind of goes back to which rule are we going to break? You got to watch them close, but not too close.
If you have any of those kind of issues, you need to bring those to my attention, please, and I'll try to resolve those. But the bottom line is, even under one-on-one observation, we had a patient, a psychiatric patient, managed to get those big bottles of hand sanitizers, take it into a bathroom on one-on-one observation with the nurse escorting, just let them go in the bathroom, and this patient ingested, I forgot how many gallons of that
That's
stuff.
happened almost everywhere.
Everywhere, yeah.
So it's extremely expensive, though, for our hospital to call in people to pay them to just be a sitter, because the psych facilities have no beds.
We're working on it.
Yeah, let me see if I can move this forward, though.
Yeah, that is a problem.
We're not going to solve it today, obviously. No. Dr. Jarvis, you're going to work on the position statement a little bit more, right? Just right.
Sure.
We'll wordsmith it, bring it back again, and in the interim, before our next meeting, can we investigate the other resources within the state, within DSHS and the mental health group you're talking about, and see if we can collaborate with them? That's probably our better avenue, I would think. And I think you have the members of this committee who are fully invested in this, are willing to spend our time doing that. This is a huge problem for everybody.
Yeah.
And it's not, the good thing is we don't have a problem. We have lots and lots and lots of problems. That's why it's hard to fix.
And when you get to the issue of, it's easy just to throw our hands up and say, well, there's no money, which is, granted, there's not. But it's easy to say that. And when you say, yeah, sorry, I give up, then the problem doesn't get fixed. And we've all heard the phrase, the squeaky wheel gets the oil. I think this is a problem that needs to squeak a little bit. And I'd like to squeak for it. And I think we need to do a little more squeaking.
Our job is to serve our patients, and this is a whole class of patients that are not being served well because of poor rules, maybe just poor facility preparation. Maybe our state needs to go to the legislature and say, you know, we need more psych facilities. We need to do a better job of sorting these patients. It's a crisis that's affecting our general hospitals in a very negative way.
I can't say, and I don't think any of us can say when we talk about how we care for psych patients, that we are not doing harm. I think we are doing the patients an extensive amount of harm. We're not helping their mental health disorder, and as a matter of fact, we're frequently exacerbating it. Droperidol and Haldol is not a fix.
Okay. More to come next meeting. That actually concludes our agenda for the next our next committee meeting. Sorry, I have down for the agenda this same issue, mental health issues, and also an issue that Dr. Phillips I know wants to talk about, and it's come up here, is the discussion of the policy statement about the use of long spine boards. That'll be on the next agenda. Is there anything else you want to say about it? Is that enough? Okay.
No, it would be an endorsement of that.
Okay.
And we've already taken it to rack chairs as well.
Okay. Any other potential agenda items for the next meeting? Yes, you can ask a question.
So a few meetings back, we were talking about clarification for medical direction of students on clinical rotations at sites. That went forward and then bounced back. Where are we at on that, Chairman?
Pretty sure that passed, correct? I'm almost positive that passed through GTAC.
I think that's one of the things I just posted on the website.
Yeah.
Thanks for the update.
You're welcome. I got the one about continuing education and the clinical supervision confused at one point, but both of those passed through GTAC.
Right, that was last time. Last GTAC, those were through.
Any other announcements?
Just one, those interested in the EMS Culture of Safety, a national document that's been closed for public comment and going through its final revisions, and will probably be published, I think, in November, December, released through the National Highway Traffic Safety Administration piece.
I have a question for Jane. Who was the lady that addressed us a minute ago about the site issues? Because I'm supposed to contact her, and I don't know who she is.
That is Renee Clack.
Renee
Clack. C-L-A-C-K.
Clack. She's a nice lady. I just needed to get her name. Thank you. And she's with.
She's with us. She's actually my boss.
Well, there's Renee. She just walked in.
Also, I just wanted to take a minute to make an announcement that after serving here, I guess, since 2005, 2006, I've decided that I need to, at this point, resign from the council and the committee, effective at the end of the year. I've taken on some roles with the American Osteopathic Board of Emergency Medicine that are very time intensive and labor intensive. In fact, even today I've had to do several things for them, and so I feel at this point that it's time for me to transition a little bit, and so I wanted to thank the committee. It's been an honor and a privilege to work with all of you guys over the years, and I'm sure that we'll be seeing each other at other times as well.
Thank you. Yeah, we definitely value your service, and but you still got one more meeting. We expect you to be there. So yeah, so November will be Dr. Phillips' last official meeting. And yeah, I see somebody for public comment in our last few minutes.
Yes, and I think there's some other comment as well. My name is G.K. Sprinkle. I'm with the Texas Ambulance Association. This is not the first committee that says, why weren't governmental entities included in House Bill 3556? And I'm going to tell you that it was a recommendation of TAA that all ambulance providers be included in this bill, and we spent numerous direct meetings with Representative Colcourse. And a reason for not putting them in is, one, that governmental entities are accountable to voters. So if they mess up, voters can go to the ballot box and take care of it. And two, that private providers are always hiding behind governmental entities and saying, oh, our governmental entities don't want it, and it causes bills on fraud or other issues to go down legislatively because private providers are hiding behind governmental entities. So it's not that we didn't try to do that, but it's that we didn't really have the kind of support from other entities. And we had governmental entity providers that are members of TAA go and talk to her, but it was not effective.
Okay. Thank you. Thank you for the clarification. Anybody else for public comment last few moments?
Justin Boyd, I'm currently the chair of the Panhandle RAC, also sit on the EMS committee. We had some things pop up in our RAC, and we did a study and a survey to determine education and paramedic availability in our area. A quick some notes. We have currently 49 EMS providers, ground EMS providers in our region. Out of those 49, 19 of them have on roster less than 5 paramedics, from 1 to 5. And then an additional 9 of those don't even have a paramedic on roster. We went back and looked at the National Registry pass ratio and determined that in our region in the last 2 years, in 2011, we had 3 paramedic programs that produced 21 paramedics. We also had, in 2011, we had 3 programs that produced 21 paramedics. So that's 42 paramedics in 2 years. Our concern is now we only have 1 educational program offering the paramedic class. What we're trying to do, I took this to the Education Committee. They're going to take it to GTAC tomorrow, I understand, with support from the EMS Committee, about possibly forming a task force to see if this is an anomaly. I went to the RAC chairs last night and asked the RAC chairs if they would disseminate the same survey that we conducted in RAC A to see if this is just happening in our area, because I also spoke with Eddie Martin, the chair of RAC K, and we found very, very, very similar numbers, that there is a giant decrease in paramedics. We want to find out if that's happening throughout the state. We'd like to have you guys on board. If we collect the information from the RAC chairs and we get this back, would y'all be willing to be on this task force or participate in looking at the data that we get and analyzing it and moving forward?
I'd like to see the data.
Yeah, bring it to us. We'll take a look. Can you bring it for the next meeting? Will you have it for November?
Do what, sir?
Will you have it for November?
I hope so. I mean, that's the plan. Tomorrow, when Dudley's going to present it at council, then I'm going to disseminate the survey out to all the RAC chairs and let them start collecting information, and we'll get that.
That really should go through council. Council should actually decide if it comes to the committee, I think, rather than the committee.
Yeah, we were
decide.
just asking if the committee was interested. The education said they were interested if council agreed to it, as well as the EMS committee. So yeah, we're going to take it to council tomorrow to see if we could form that work group, or at least have the 3 committees work together on it.
So I would suggest in those other areas you also look at other allied health professionals, not just paramedics, because obviously I know you're going, schools are shutting down because of that poor accreditation system. So it may be beneficial to also look at other. Is this just paramedicine, or is this also nursing and other things in those same areas? Okay. Otherwise, you're not getting a true picture.
Okay. And is the same thing happening in other states also? Just to isolate the variables. It may be that people find EMS less attractive now, or it may be a healthcare in general. I don't think that's the issue, but that may be.
And I think the key in where I think we're going to, oh, sorry. I'm the one saying go to the mic, and there I am yelling. I think the key to this right now is we don't know what it is.
Yeah.
I mean, the Panhandle's traditionally had issues. The other RAC that he mentioned didn't have, and we're purposely not saying this is an accreditation issue. What this is an access to paramedic issue. And because the other RAC didn't have any education institutions in the beginning, before that. So they didn't have any that accepted civilians. And so the concern is that there's an ever-growing, in the rural areas where it is apparent that paramedics really do make a difference, there's a growing need for paramedics, and what can be done, what can we come up with as ideas to be done to help address that problem? If that's, well, anyway, we could go on and on. We don't need to solve it here, but
You
that's...
can only go for 35 seconds.
That's the only...
You made him have a seizure.
No, here's the cool, because it's so loud.
Yeah.
You want the basketball buzz?
It's so loud and bothersome now, she just comes around here and shuts it off. So then you've got all the time in the world after that. So.
Kind of like most of All right. I have a motion to end the meeting. There we go, we're good. We're done. I think they want to hear the buzz. I think they really want to hear the buzz, to be honest with you.